The hand was now markedly swollen, gangrenous, diagnosed with septic shock. Antibiotics were started. Blood and wound cultures grew out gram-negative rod that was oxidase positive with pink colonies on McConkey. It required 3 to 6% sodium chloride for growth. The ID system could not yield an acceptable ID. It was ID'd finally through traditional biochemicals. Patient suffered cardiac arrest and died 11 hours after admission. So this started 12 hours before, he died 11 hours after, so 23 hours after infection, he was dead. Vibrio, as you'll learn, loves salt. It is a saltwater organism. Hence the pricking his finger, scraping shrimp. That's one of the places you're going to find it.
Is it pretty common?
Fairly, yeah. You live around the ocean, it's pretty common. So Vibrio, there are 110 species of Vibrio. 10 of those have been found in human clinical specimens. They are found in a wide variety of aquatic environments. It can range, depending on species and rate amount of infection, from mild GI symptoms all the way to cholera. Cholera is a devastating diarrheal disease. Death by diarrhea. It can come from a simple wound infection. It can develop into fatal septicemia. Factors that contribute to or indicate Vibrio infections, think seafood. Anything related to seafood. Eating raw seafood, never recommended, especially oysters. Why you would only want to eat a raw ball of snot is beyond me. Recent immigration or foreign travel. Gastroenteritis with cholera-like or rice water stools, which we've talked about in earlier chapters. Accidental trauma incurred during contact with fresh or marine water or associated products. So messing with shellfish, fish hooks, you're out sailing with some buddies, you get a rope burn pulling in the mainsail, anything like that. Any kind of wound associated with water or any kind of consumption of water organisms, and you are technically at risk. Microscopic morphology. They are non-spore forming, small gram-negative rods. They can be highly pleomorphic, may be curved in the gram stain from the original specimen. They almost look like, if you look at that, like they're trying to be a spiralis. They almost try to corkscrew. They are facultative anaerobes, catalase and oxidase positive. Oxidase positive is in red for a reason. I want to remember that. They reduce nitrates to nitrites. Most are susceptible to a vibriostatic compound called O129. They actually have that in what they call a vibriostat disc. It's an antibiotic disc that has O129 in it. This stuff doesn't like that. Most of them are halophilic, except for the cholera. You might want to guess what halophilic is.
Like salt.
They like salt. They love salt water. Antigenic structure, you don't need to know. You can serotype based on those O and H antigens. So the one that is not necessarily salt-loving, but the big one of the group that you need to know, Vibrio cholera. Any of y'all are old enough to have played the old school game, Oregon Trail.
Yeah. Oh, yeah.
You always die of cholera or dysentery. I like to die of cholera a lot in that game.
You know you're supposed to let everyone in your group die so
Yeah.
that you can make it through?
Yeah.
You just kill them all right at the beginning.
Jesus. What game is
So
this?
cholera is
Oregon
endemic
Trail. It's a
in
really
developing
old game.
countries.
It's really hard.
B. Cholera 01 is the causative agent of Asiatic cholera, also called epidemic cholera. It occurs in two bile groups, classic and L-Tor. L-Tor has been the predominant bile group in the last two pandemics. It had a resurgence in 1992 that is still going on, causing widespread cholera in India and Bangladesh. And it is already anticipated that this one will be the cause of the next pandemic of cholera. Because it's still there, it's still occurring, Bangladesh and India. All we need is for the right person to jump on an airplane and come visit New York City, and there you go. It is a acute diarrheal disease, spread mainly through contaminated water. This one is one that was not halophilic. It does just fine in salt water. So, I mean, we don't drink salt water. So if it only lived there, it would not be an issue. This one's just fine in fresh water. And hence the problem. Outbreaks are also seen from improperly preserved and handled foods. Fish, seafood, milk, ice cream. Severe gastroenteritis, vomiting, numerous stools, and we're talking 10 to 30 times a day, characterized as rice water. The problem with it is the rapid fluid and electrolyte loss due to that much diarrhea, causing hypovolemic shock, metabolic acidosis. Death can occur in a matter of hours. And the symptoms from this are due to the enterotoxin, cholera toxin, also called collagen, which causes hypersecretion of electrolytes and water into the intestine. This toxin basically goes into your water, into your bloodstream, and says, dump all the water and electrolytes into the guts and eject. And that's why it can be so rapid. And if you just think about it, if you're having diarrhea 30 times a day, I mean, yeah, that's rapid death. You can't even consume that much water. You can't replace what you're losing. Even if you were in a hospital and they're running IV fluids in you with electrolytes, it can't keep up with that. They got to stop that somehow. Vibrio parahemolyticus is the second most common. This disease is usually self-limiting. This is the causative agent of what's called summer diarrhea in Japan. So you might want to associate this organism with that disease. It's been isolated in nearly every coastal state in the U.S. There was a pandemic strain that emerged after 1996 and has been implicated in numerous foodborne outbreaks all over the world. It's found in aquatic environments and associated with marine animals, again, oysters, sardines, shrimp, crabs, you think any type of seafood. Most cases are traced to recent consumption of raw, improperly cooked, or contaminated seafood. Again, those nasty oysters. Raw seafood, you're asking for it. Clinical manifestations, cramps, vomiting, little to no fever. Just think abdominal cramps, watery diarrhea, can occur 24 to 48 hours after ingestion. Generally self-limited. And it can produce a red cell lysing agent called that Kanagawa phenomenon. They're not sure the exact, how exactly that works. But this is something it's very possible you've had. I mean, has anybody ever had a stomach bug that lasts 24, 48 hours, diarrhea, maybe nausea and all that, and then goes away? Very possible. Like I said, usually self-limiting, lasts a day or two. Not nearly as severe as the cholera, of course. So this is one, there's a chance we've had. I mean, you could get this just drinking the water, much less anything else. If you've ever been swimming in the ocean and salt water gets in your mouth or up your nose, you can get it. Vibrio vulnificus. Did you know this is the one that's known as the lactose positive Vibrio? This is a reportable finding to state health, so if you find this, you have to report it. Found in marine environments of coastal North America. After cholera, this is the second most serious type of Vibrio infections. Not the second most common, the second most serious. Can cause primary septicemia, which is GI route after consumption of shellfish, especially oysters. Mortality rate 40 to 60%. Far more common is the wound infections. Invariably have a history of some type of traumatic aquatic wound that presents as cellulitis. Fish hooks. Yeah.
Okay, so cholera is not only the most common, it's also the most serious.
Yes.
Okay, thank you.
So fish hooks, walking around in the water, cut your foot on a rock. Some idiot that threw a beer bottle in the ocean and you cut your foot on a piece of glass, which I've been fortunate enough to do in Destin, Florida. I wish I could find the culprit because I would love to have shoved that broken beer bottle into a nice warm spot. It will present as cellulitis. There's a case study according to that, the one we read. It'll present as cellulitis. It can jump to the bloodstream and it can be fatal. Unfortunately, again, it's fairly common. If you've been in the ocean off the coast of North America, you have been exposed to this. It is in the water everywhere. If you have an open wound, that's all it needs. The next one, Alginolyticus. It's the least pathogenic of the 4 species most likely to encounter in the lab. Very infrequently isolated. Again, marine environments. This one is a strict halophile. Only going to find it in saltwater. Has been found in eye, ear, wound, and burn infections. Maybe an occupational hazard for those in constant contact with seawater, fishermen or sailors. Eye and ear infections is probably the most common way it's going to be seen, swimming in the ocean. Get swimmers here with this stuff, get it in your eyes, you end up with like a pink eye like conjunctivitis. Wounds, again, cut your foot, wandering around in the ocean, fish hook, whatever. Burn infections. If you've got an open burn, you should not be swimming anyway. I mean, because that is an open wound and you're just asking for whatever you get at that point. But again, most of these is going to be a problem right here. Fishermen and sailors, they're in constant contact with this stuff. So, laboratory diagnosis. They are not fastidious at all. Specimens should be transported in transport media. Not necessarily. As long as you're going to set it up in a proper amount of time. You're not going to throw it up on the counter for 6 hours. You don't need to transport media. It's not that fastidious. For culture media, the salt concentration in most routine media is sufficient. Because you think about it, there is salt in blood. That is enough salt for most Vibrios just in a regular blood plate. So it'll grow just fine on blood, chocolate. They will appear smooth, opaque. They can be a little bit iridescent with a greenish hue. On MAC, most of the pathogenic ones will appear as non-lactose fermenters. They'll be clear. The exception, vulnificus, that's the lactose fermenting Vibrio. It will be pink. On MAC, those clear colonies, whether we're talking stool cultures or anything else, that's usually our biggest concern. That's what we're looking for, is those clear colonies. TCBS is the most commonly used selective media and usually inhibits all other organisms. You need to know that. It will differentiate sucrose fermenters from non-fermenters. If they ferment sucrose, they will be yellow. If they do not, they will be green. If an enrichment broth is desired, alkaline peptone water with 1% salt can be inoculated and incubated 5 to 8 hours before you subculture it. Most people don't have that. But if we think we really have a halophile, what most labs do have is that 6.5% sodium chloride that we use for what organism? Think back. Enterococcus group D strep.
Yep.
Remember that 6.5% sodium chloride?
Yep.
You can use that for this, because if it's a true halophile, it'll love that environment. And most labs will have that. This peptone water with 1%, that's not something anybody's going to routinely stock. TCBS, which this will be in your book, is thiosulfate citrate bile salt sucrose. So cholera on TCBS agar. It ferments sucrose, so they appear yellow. The problem with TCBS agar is if you're not looking at the back of the plate, it looks just like HE agar. You have two plates side by side, and you have to actually read the writing and see which one you're dealing with. Yeah, nothing real special, real specific right there. Nothing real indicative. But it does ferment sucrose, so it will be yellow. Parahemolyticus, volnificus, they will be green. They are non-sucrose fermenters. So presumptive diagnosis, if you put that O129 disc on there, and it doesn't grow around it, that's presumptive diagnosis for Vibrio. That will help you separate Vibrio from Aeromonas, which are very similar. The positive oxidase will separate Vibrio from the Enterics. The fermentive metabolism will separate it from Pseudomonas. Pseudomonas is a non-fermenter, which we'll talk about today too. The rapid methods, these fancy high-dollar machines we have in the lab, they're not equipped to deal with Vibrios. They can't ID them very well. Most authorities advocate ID with conventional biochemicals, supplemented with salt. This is one of the rare times that you're going to see labs break out the traditional old school biochemical tubes like we've played with in there. Routine hospital labs are not going to do this. They're going to send it out to reference. This is part of the reason we still cover traditional biochemicals, although they are phasing that out. But it can never go away completely because of organisms like this. We're not to the point where we can just stick everything on the machine and get an ID. Sometimes we got to go old school on it. Serology is sufficient to presumptively screen cholera isolates. You cannot give a definitive ID based off that, but you can give a presumptive ID so that they can start treatment and then send off for confirmatory testing at reference lab. Antimicrobial susceptibility, there our traditional methods work just fine. The machines can do the susceptibility. They just can't do the ID very well. Generally susceptible to doxycycline or Cipro. I'll take Cipro, thank you very much. I don't like vomiting that much to take doxycycline. And again, Cipro is my favorite antibiotic. That's the fastest antibiotic I've ever seen in my life. But this is one of those that, can the antibiotics work fast enough to slow down the diarrhea in time to save your life? That's kind of a toss-up. Aeromonas, the most important thing about Aeromonas is it lives in a lot of the same environments as Vibrio, and we have to distinguish this from Vibrio. This can cause its own infections, but nowhere near as severe as the Vibrio ones. Found in fresh and marine waters worldwide, frequently isolated from retail produce sources and meat products. Produces disease in a variety of cold and warm-blooded animals, fish, reptiles, amphibians, humans, whatever. This organism used to be a Vibrio, so now it's in its own little family. There are 21 species, only 8 of which matter, classified into 2 main groups: mesophilic, which likes body temp, and psychrophilic, which likes it a little bit cooler, room temp. All of them will typically grow anywhere from 4 to 42. They just have their preferences. Notice the unique pattern at the bottom. Seasonal pattern of isolation from May through October. What is occurring May through October?
Summer.
People are at the beach, people are swimming, people are going on vacation, etc. So that's when you're most likely to pick this up.
Okay.
Again, it can be found in produce and any of that stuff, because even though it may be winter here, we're importing lettuce from Mexico where it's still summer. They're watering the lettuce, you can pick it up. And of course then animals as well, because no matter how warm or cold it is, they're still drinking the water, so. Clinical manifestation, primarily intestinal. They're recognized as an enteric pathogen. Patients with diarrhea caused by this have a history of aquatic exposure. There are 5 diarrheal presentations, one of which is referred to as traveler's diarrhea. Can cause extraintestinal infections. Septicemia, meningitis, wound infections are the most common, although various other infections have occurred. Basically, this is going to infect wherever it gets. Wound infections will invariably involve recent traumatic exposure to the extremities. Go right back to the fissure. Septicemia or cellulitis setting up at the point of wound. Aeromonas hydrophila infections have been found involving the use of leeches in plastic surgery. Yes, we still use leeches in surgery. They do have their place in this world. Unfortunately, if your leeches are infected, then they infect the patient, and it's wonderful.
I mean, they use laboratory grown leeches, don't they?
They do now. This is why. They didn't for a long time. They'd go scoop a bunch of leeches out of the pond and they'd rinse them off and they'd save them they'd use them over and over, but now they're born and bred and all that for medical purposes. I don't care about those last ones. Baronii, Biobar, Sobria, typically immunocompromised patients, history of liver disease, dysfunction, etc., underlying illnesses. Culture media for Aeromonas, they do just fine on our routine media, stool culture media. They will appear large, round, raised opaque, often mucoid. They have a strong odor. Pigmentation can vary a little bit. They can be anywhere from a translucent to a white or a buff color. Hemolysis on blood is variable. Most will show beta hemolysis. Gram stain will differentiate it. I mean, it'll look like a staph on blood, but as soon as you do a gram stain, that's going to rule out staph. Very easy to overlook on McConkey because they will ferment lactose. They'll look just like an E. coli or anything else that's normal flora in a stool culture, so it's really, really easy to overlook Aeromonas. May need to add a modified CIN auger. You need to look that one up. You need to know a little bit about CIN. Presumptive ID, perform an oxidase and a spot indole on beta hemolytic colonies off of that blood auger. The positive oxidase will distinguish it from the enterics. Most of the aeromonads are endo-positive. You can use the Vibrio Static O129 to distinguish aeromonids from Vibrio, and the ability of the aeromonids to ferment will separate them from the Pseudomonas. As far as definitive ID, the machines are real iffy on this. It can identify some and not others. This is one of those, when you get to an Aeromonas, it's going to be a send out. You're going to have to send this out to reference. Again, they're going to go back to conventional biochemicals most of the time. They may even have to go old school on the susceptibilities and use the paper disc, antibiotic disc, to get your susceptibilities on it. These machines we use are designed to function with the common stuff. It struggles with some of this stuff. Flowchart. You don't need to know all this. The only organism I really care that you know much about is Hydrophila. You don't really need to know much about the rest of them. Most of the time, Aeromonas infections will be self-limiting. Antibiotic therapy is often still indicated. It's always warranted in wound infections and septicemias. According to your text, susceptibility studies should be done by the old school Kirby-Bauer method. Almost all of them are resistant to penicillin, ampicillin, and carbenicillin. They're generally susceptible to the aminoglycosides, trimethoprim sulfa, and quinolones. No, don't memorize that. Main thing you need to know is that you're going to have to go old school for the susceptibility on this. Plesiomonas used to be a Vibrio. Recent evidence suggests this organism is very similar to Proteus and has been recently moved to the enterics. You should remember this because it is oxidase positive. It is the only one of the enterics that is oxidase positive. It is glucose fermenting, facultative anaerobe, gram-negative, motile, non-spore forming rods. Shares a lot of biochemical and antigenic features with Shigella, and that's where the species name comes from. Plesiomonas shigelloides. It is the only species of the genus and has a much lower virulence than Shigella. It mimics Shigella in a lot of ways. It's just nowhere near as potent or as bad as Shigella. This is one I suspect they'll probably be moving again. They moved it from Vibrio to the enterics. They still are not happy about that oxidase reaction being in the enterics, so I suspect they'll move it again. This one is found in the soil and aquatic environments. Generally found only in fresh and estuarine water of tropical and subtropical climates. Estuarine water is a mix of fresh and salt water, so it's lower salt concentration. Marsh. It doesn't like the full-blown salt concentration of the ocean. Widely distributed, warm and cold-blooded animals. Pigs, vultures, dogs, cats, snakes, fish, etc. I guess if you eat a vulture, you deserve it. It is a potential cause of enteric disease in humans. Looks very similar to E. coli on the enteric media. It could be underreported. Has also been found in extraintestinal infections, wound infections, etc. Again, if we're doing a stool culture and it looks like E. coli, we don't care, because E. coli is supposed to be there. So when you're looking at a MAC plate and you have pink colonies, you don't pay any attention to them. So that can be a problem. But since this is typically self-limiting and minor, it's not that big a deal. Gastroenteritis has caused 2 diarrheal outbreaks in Japan and 1 in Cameroon, usually from contaminated water. We know the Japanese like their uncooked seafood. So abdominal pain, fever, vomiting, usually self-limiting. Give antibiotics if it's a prolonged or severe case. Extraintestinal infections, that's gonna be occupational exposure again. Since animals carry this, your vets, zookeepers, fish handlers, they found this in aquatic athletes, triathletes. You go run 400 miles and then jump in the ocean and swim 100 miles and then jump on a bicycle. That you hate yourself if you're doing that. You have to. Culture media grows just fine on routine media. The colonies are real shiny, non-hemolytic, slightly raised center. Most of them will ferment lactose. Should screen colonies from blood or chocolate for the oxidase. And inositol brilliant green ball salt tartar. You don't even remember that one. Won't grow on TCBS, but will grow on CIN. I want to remember that one. So the identification, oxidase separates it from the enterics. Sensitivity to O129 separates it from Aeromonas. Its ability to ferment inositol and separates it from all the Aeromonas and nearly all Vibrio species. And it does have enough positive results that rapid ID systems can pull this one off. The reason your rapid ID systems fail on some of these organisms is when it's negative for so much stuff, it doesn't have enough positives to work off of. Think of it as doing an antibody screen and you've only got one positive. Hard to ID something off of that. And that's the same problem you have with some of these organisms. When they're so biochemically inert, some of them, hard to ID them. For antibiotics, most cases self-limiting, not going to use antibiotics. If it's severe or extraintestinal infections, especially among babies, they will get antibiotics. This is naturally resistant to penicillin. Quinolones, cephalosporins do appear to be effective so far. Could change any day. So Aeromonas, Plesiomonas, know the basics, don't care much about it. This one you do need to know about because this is one of the bugs we're looking for in stool cultures. Campylobacter. Campylobacter and Campylobacter-like organisms. Heliobacter and Wollenella. Never in my life seen Wollenella and I don't expect to. All these are now grouped into their own family. Campylobacteriaceae. Campylobacters were once classified with the Vibrios because of their characteristic microscopic morphology and the positive oxidase. They're those little negative curved rods. They look a lot like Vibrio. Infections are attributed to direct contact with infected animals and pets, and indirectly by consumption of contaminated water, dairy products, improperly cooked poultry. They're primarily a zoonotic organism. Sexual transmission has been reported. This is an intestinal pathogen. If it's transmitted sexually, you can draw your own conclusions there. Campylobacter jejuni is the most common cause of bacterial gastroenteritis worldwide today. You need to remember that line. Populations most infected include children less than a year old and adults between 20 and 40. Those next two I don't care about, coli and Larry, I think it's pronounced. Campylobacter fetus has been isolated from blood cultures, rarely causes GI illness. Campylobacter species have been known to cause abortion in domestic animals. They are studying whether or not this will cause miscarriage in humans as well. They have not, they strongly suspect, but they have not made that link yet. H. pylori linked to gastric, peptic, and duodenal ulcers. I've been lucky enough to have this one. It's great. Hard to kill. H. pylori is found in greater than 75% of gastric ulcer patients. Currently recognized as a major cause of chronic superficial gastritis, called type B gastritis. It is estimated that half of the world's population is infected with H. pylori. Fresh groundwater is the likely source of many infections. I was raised my entire life up to the age of 21 using well water. There was no city water where I grew up. I grew up out in the woods. Why is H. pylori significant if it just causes ulcer? It has also been linked that stomach ulcers formed by H. pylori, if left untreated, will 100% turn into stomach cancer. I was having a lot of stomach problems. I was getting up every morning nauseous, my stomach hurt, and all this was going on for like months. And I finally decided I was working at the lab, and I said, the heck with this. I said, I'm testing myself for H. pylori. And it was positive. I go to my doctor, told him what the deal was. He said, well, your symptoms fit. The positive test result was the least significant because the test we did would just show if you have ever had H. pylori, not if you had a current infection. He said, but your symptoms match, you've never been treated for it, so we're going to treat you for it. I was on 4 months of 3 different antibiotics to kill this stuff. Man, it's hard to kill. But again, half of the world's population is infected with this stuff. Since I also grew up drinking the same well water as my grandmother, she complained to her doctor for 20 years with acid reflux, indigestion, her stomach bothered her all the time. So they were giving her Zantac, Rolaids, all this stuff for 20 years. She died of stomach cancer. Completely undiagnosed. They never scoped her. They never looked. To my knowledge, they never tested her for H. pylori. Chances are she got it from the same source I did, her well.
Question.
Yes.
Did you ever figure out what antibiotic did help you?
No, because I was taking them all at the same time. They give a cocktail for it because it's so hard to kill. So, clinical manifestation, Campylobacter, mild abdominal pain, 2 to 10 days after ingestion of the organism, cramps, bloody diarrhea, could have fever and chills, not always, rarely nausea, vomiting. It's usually the diarrheal disease. Usually self-limited, untreated patient can remain a carrier for months. H. pylori linked to gastric infections. Organism colonizes stomach for an extended time, producing chronic superficial gastritis. The host mounts an antibody response, although the antibodies are not protective. People always thought ulcers came from stress or chemical irritants. You drink too much tequila. And they think that gives you ulcers. And then they figured out, no, most people it's H. pylori. It has nothing to do with what they're consuming or their stress levels. Speculated that long-term infection with chronic gastritis is an important risk factor for gastric carcinoma. They've done more than that now. They have proven that link. If you have H. pylori for a long period of time and it's untreated, you are almost assured of getting stomach cancer.
What's the specimen for testing this?
You can test for it with serum, which is how I did mine. I grabbed a needle and drew my own blood and spun it down and tested myself. The other way they do it is stomach biopsy. When someone has ulcers and they're untreated and they actually go in and scope them the way you're supposed to do, they'll go in and look and they'll grab a small tissue specimen and test it. And I think the next slide may show you, tell you how. Specimen collection and transport for Campylobacter. Blood cultures, stool cultures, gastric biopsy material. Culture media, Campy blood agar. It's an enriched selective agar commonly used to isolate Campy. Campy blood auger contains a Brucella auger base with a combination of antimicrobials. Also use Campy CBA and these other ones, Butzler and Skiros medium. H. pylori usually diagnosed by non-culture methods. Remember, Campylobacter and other Campies grow best at 42 degrees. You don't want to throw these in a regular incubator. All micro labs that actually culture Campy have a 42 degree incubator just for Campy. And at like National Park, all of our stools were set up at 42 degrees. We had all of our plates for regular stools went in the regular incubator, and our Campy plate went in that 42 degrees. They want their microaerophilic and capnophilic. The ideal thing for this would be a candle jar. Not allowed to use that anymore. So now we have the special Campy bags. You put it in there with the reagent, seal the bag, and then pop the vial of the reagent, and it produces this environment. So we can do it without open flames. So you have to know, if you don't provide this environment and that temperature, you're not going to isolate Campylobacter. Most people, because of all this, it's so hard to grow, but it's so significant, have gotten away from culture and Campy. CHI just very recently did it. Now they do it molecular. They take a swab of poop and they stick it in a machine, and it looks for, what is it looking for? Salmonella and Campy, I think. They just do it off swab. Yeah.
Is it looking for the RNA?
I don't know enough about the machine to know. I assume so.
Because the RNA in the little critters is what the genetic information is stored in, as
Yes.
opposed to the DNA.
Yes. It is using a method similar to that. Becky at National Park is using a different method. She's using some sort of a serological kit test to detect Campy because it is so notoriously hard to grow. Again, it seems like the stuff that is really, really significant to us, for whatever reason, it's hard to grow. If it's that big a deal causing disease, I mean, if it grows that easily in your body, won't it grow that easily on the plate? They're too finicky. They don't like it. But Campy, you have to know, 42 degrees, microaerophilic, capnophilic. Presumptive ID, stool and rectal swab isolates can be presumptively ID'd by positive oxidase, gram stain morphology, and characteristic motility. What's wrong with that line? Don't gram stain stools.
Yeah.
Anywhere there's a lot of normal flora, you don't gram stain. If you did, that would help you. Characteristic motility. Right there. Part of your homework. It moves, but it moves in jerks. It darts. It like jumps forward. Heliobacter rods are curved, non-spore forming. Gram-negative rods, enteric campies may appear as long spirals, S-shaped or seagull wing shapes. Remember that. Exhibit characteristic darting motility on hanging drop preps. We'll talk about that shortly. The organism stained poorly. It's recommended to use carbofuscin stain as a counter stain or extend the safranin time 2 to 3 minutes. What you're going to do the first time if you gram stain this, which it's a stool and you shouldn't, if you gram stain the first time, you're going to see these gram-negative rods and they're going to be really, really faint, very, very light. So you're going to gram stain it again and this time triple the safranin time. Darken those up to where you can see them better. Minute and a half, 2 minutes is usually sufficient. You could go longer to make them even darker if you wanted. It says up to 3 minutes. Colonial morphology, Campylobacter and the other enteric campies appear as moist, runny-looking spreading colonies. When we're talking spreading colonies, and we're not talking about swarming.
It just looks like, it's runny. It looks like snot and it's just kind of spread out. It's not like it's swarming outwards. It's a little bit different. They're usually non-hemolytic. Some will be round and raised, others will be flat. Usually, it says some enteric canopies produce colonies that are tan or slight pink. They will usually be tan. Definitive identification, positive hip-urate hydrolysis is an important characteristic. So, identification of H. pylori, rapid urease production. That urea tube y'all did, if you put H. pylori in that urea tube, it's going to turn it hot pink in just a matter of a few hours. It's very rapid, positive for urea. Gastric tissue sample placed on Christensen's urea and incubated 37 degrees for 2 hours. It will produce a rapid color change. Another rapid commercial system is the Clow test. I'm very familiar with the Clow test. We'll talk about, I think I've got a slide on that. Urea breath test. This is a good one. I've had to do this on outpatients a few times. You give the patient, let me explain how this works. You've got 2 balloons for all intents and purposes. They have a one-way valve, so you blow it up and the air don't leak out. You hand them a balloon, they blow it up. You then give them this disgusting drink to drink. And what it is urea that's labeled, ours was labeled with carbon-14. They drink this. They wait 15 minutes and then blow up balloon 2. Their urea will be degraded by H. pylori in the stomach, and it will release carbon-14 CO2. Which is absorbed into the bloodstream and detected in exhaled breath. So, bag 1's like your control. Bag 2, they're going to be testing it for carbon-14 CO2, which will prove the carbon-14 urea was degraded by H. pylori and expelled into the breath. It's a neat test. You get and it's always funny because they come in and I say, okay, we got to test you for H. pylori. They're like, okay, do you need urine? Are you going to have to stick me where you need? No, I said, no, you're going to be blowing up balloons today. They're like, huh? Swear to God. That's it. You got to blow up 2 balloons and drink some nasty stuff. I mean, it's easy, it's quick, and you pack up, it's a special kit. You pack the balloons in there, patient information, mail it off. There are fecal antigen detection tests, PCR tests, serology, antimicrobial susceptibility not routinely performed, erythromycin and azithromycin usually work just well, although most will recover without that. This is that Clow test. When they go in and do the scope, they get that little biopsy of tissue. And this is urea. And that is actually a piece of the skin or the stomach lining. And they poke it down in that urea, label it patient information, send it to microbe. And the top is what it'll do if it's positive. And I think we're almost at the end of this. Yeah. Turn this off for a second. So the stomach is shaped somewhat like this. H. pylori is going to go over here all the time. It wants to be living in this area, so they'll run this scope down, and this is the area they're looking at. If they see anything abnormal, too red, anything like that, they're going to grab a piece. Especially if they see an ulcer, they're going to get to the edge of it. Especially if it's a bleeding ulcer, they don't want to make it bleed worse. They're going to get to the edge of it and get a piece, bring it out. And then they put it in that Clow test and send it to us. And they're that big. The little urea in the middle is smaller than the size of a diamond. Just a little plastic card.
What area is not the fundus, is it?
Fundus?
Of the stomach. That's the,
Reach me, I don't remember.
so the inferior aspect of it?
Yeah. Input, output, it's on the output side. That's how much I know about it. Now, we talked about looking for motility with the hanging drop method. Works very, very well for motility, kind of hard to perform. So you've got your slide here. And you're gonna make a ring of wax, parafilm, paper, whatever. What you wanna do is elevate your cover slip. So you're gonna put something on the slide to do that. You're going to put a drop of the liquid or whatever that you're wanting to look for motility on that cover slip, and then put it here. And that drop is like that. Hanging drop method. And that is the best way to look for motility. Because you're looking this way through the scope, but nothing is touching, it's not being squished, it's free to move, there's no constraint. So the hanging drop method, you'll see over and over, is the best way to look for motility. I don't do the hanging drop method, because I can see motility on just a normal wet prep, like you do for any other urine microscopic. But the textbook answer, if you're looking for motility, they want you to do this hanging drop method. So that's what the hanging drop is. But again, it's kind of a pain, because you gotta get your slide, you gotta put some sort of support for your cover slip on it, all that jazz. All right, take 15. We'll talk about some 2 months. Miscellaneous stuff. You think none of this is important. Well, one of them is very important. Aerobic gram-negative bacilli can be divided into at least 2 large groups: fermenters, non-fermenters. Your fermenters primarily are your enterics. General characteristics. Most of them are oxidase positive. This will separate them from the enterics. They're ubiquitous in the environment. They're in soil, water, plants, foodstuff. Most of them prefer a moist aerobic environment. They are found in hospital fluids and devices such as catheters, nebulizers, etc. They are rarely part of normal flora. They can easily colonize hospitalized patients, especially the immunosuppressed, obviously. They tend to be resistant to multiple antibiotics. Of the non-fermenters, 3 genera make up the majority of isolates routinely seen in the lab. Number 1, by a large margin, Pseudomonas aeruginosa. The next word I've heard pronounced 2 different ways. Nobody will tell me which is right. Acinetobacter and Acinetobacter. Take your pick. I don't care. Stenotrophomonas multifilia. Very rare. I've seen it once. And then the other, including Burkholderia species. Again, by and large, the biggie is Pseudomonas. Clinical infections from these organisms, a number of them. They can cause septicemia, meningitis, osteomyelitis, wound infections. It says wound infections usually following surgery or trauma. They like deep wounds, for what that's worth. Risk factors, immunosuppressed, shouldn't even need to say that one. Trauma, foreign body implantation, and infused fluids. Biochemical characteristics, thin, gram-negative bacillus, oxidase positive. Note it can be weak or variable. It'll be oxidase positive. Some of them may just barely turn that swab purple. It'll be light, but it'll be there. Non-reactive in commercial kit systems for the ID of enterics. So you look at something, you think maybe it's an enteric, and you go to ID it, and everything's negative. Probably wasn't an enteric. They're non-fermenters. So on a TSI, there is no acid production. And again, resistant to a wide variety of antibiotics. I don't care about the first one. I don't care about the next one. Do I even care about this whole slide? Not really. Except for that last line. They're constantly studying the DNA and RNA of these organisms, and they are constantly shuffling them around. As far as what group they're in, let's change the name of this and move it over here and all that. These are a problem. You'll learn all these names, they'll change them again. Except for Pseudomonas aeruginosa, they haven't changed that one in years. I assume it will stick. So the genus Pseudomonas accounts for the largest percentage of all non-fermenters isolated in clinical specimens. You see Pseudomonas a lot. Common characteristics, gram-negative bacillus. They are motile, pretty much oxidase positive and catalase positive. Will usually grow on MacConkey agar just fine. Usually an oxidizer of carbohydrates, although some are asaccharidic. They're not a fermenter, they can be an oxidizer. Pseudomonas fluorescent includes all those different species. The one I care about, Pseudomonas aeruginosa. It's the most commonly isolated species. It is the leading cause of nosocomial respiratory infections. Causes a wide variety of infections: skin, wound, UTIs, bacteremia, infections following burns, surgery, pulmonary disease, and cystic fibrosis patient. Third most common cause of gram-negative bacteremia after E. coli and CLED. Accounts for 75% of cases of nosocomial bacteremia. Also causes jacuzzi or hot tub syndrome. I hadn't that pleasant since I have a hot tub. Causes a necrotizing skin rash. Yeah, it's nice. Enjoy a little time in the hot tub, your skin falls off. It's great. Does produce endotoxin and exotoxins. Motile, has pili, has capsule, resistant to number of antimicrobials. I've been convinced, I've had this discussion with Becky at National Park. I am convinced at this point that Pseudomonas will be responsible for the zombie apocalypse. 15 years ago, Pseudomonas was resistant to almost nothing. Now, when you do a susceptibility against 12 to 15 antibiotics, it'll be resistant to 14 of them. It is difficult to kill this stuff. It is becoming hyper resistant to some of this stuff. Identifying factors: produces pyoveridin, a yellow-green pigment that fluoresces under UV light. Most strains also produce pyocyanin, which is a blue pigment. Only Pseudomonas aeruginosus produces pyocyanin. Put those two together and you get the green color characteristic of Pseudomonas aeruginosa. It is notoriously green. It's a green spreading looking colony. It definitely has that green color. Beta hemolytic flat spreading colonies with a metallic sheen, metallic green sheen. Not as metallic as like the E. coli on E and B, but very greenish. Many strains have a fruity, grape-like odor. Can grow at 42 degrees. This is one, I have a problem with this odor too. A lot of people agree that Pseudomonas smells like grapes. I disagree. I don't smell that sweet, fruit-like odor. I smell stink. We will grow it. We'll let you smell it and see what you think. Like I said, one particular tech I work with, she loves this stuff. Every time it grows, she's sniffing it. I don't like it that much. Fluorescence and Cutida, very low virulence, rarely cause disease. They can grow in the refrigerator, but not at 42. They will produce only pyoveridin, not pyo. Should be cyanin, should be a Y in there. Does it look green on the slide? It doesn't on mine.
Maybe a chance.
Nah, that's terrible. We'll grow that for real, we'll do better.
Right.
It doesn't even look
doesn't
green
look
on
right.
this.
Really?
Their plates expired. Their plates expired in 1983.
Oh, boy.
These organisms, just know the name, Spetzeres, rare. Mendocina, found in soil and water, usually considered a contaminant. Luteola or rhizohabitans, they have no idea what the natural habitat is. They do tend to find it in soil and water. Has been isolated in wounds. It's kind of significant because they found it in dialysis fluids before. Okay. Acinetobacter, Acinetobacter, whatever. This one you don't see a lot. It's a problem when you do see it. I'll tell you why in a second. It now belongs in Moraxella. Moraxella is a gram-negative cocci, is it not? MCAT. Acinetobacter is a gram-negative rod. So why would they ever think about putting it in that family? The problem is, this is a coccobacillus, and I mean stress the cocco part. When you look at this on a gram stain, it looks round. It looks like gram-negative cocci. Maybe they're slightly egg-shaped. It is very hard to call this a bacillus. When I was in clinicals, I got it wrong every time. They'd show me a gram stain, or they'd give me a sample, and I'd gram stain it, gram-negative cocci. They'd say, nope, gram-negative rod. I'm looking at it like, there ain't no way. This one's tough, and that's why. And that's why they stuck it in Moraxella, because it kind of looks and acts like it. The two species you need to know about, Beaumontii and Lomofii. Love these names. They're ubiquitous in the environment, soil, water, food stuff. Associated with ventilators, humidifiers, and catheters. Ventilators, humidifiers, it's another one of those respiratory problems. This is one of those bugs that used to contaminate their machines before they started figuring out they need to do a better job about this. Some adults will carry this on their skin and in their pharynx. Hospitalized patients become easily colonized. They used to be considered, when they find this, insignificant. Then they start learning better, because they're starting to see an increased number of isolates with multiple resistances, is that a word? To antibiotics. So they're having to take this seriously, especially in respiratory or urine specimens. I'm pretty sure that YouTube link probably doesn't work anymore. Clinical infections, they are opportunist. They cause 1 to 3% of nosocomial infections. Second only to Pseudomonas in the frequency of isolation as far as the non-fermenters. Beaumontii is the more virulent genus, becoming increasingly resistant to antibiotics. Referred to as crab. Carbapenem resistant Acinetobacter beaumontii. Been associated with UTIs, pneumonia, tracheobronchitis, and endocarditis. When it goes to the heart, 22% mortality rate. Again, it's so hyper-resistant to antibiotics, when it gets somewhere really problematic, we can't kill it fast enough. Has jumped to the blood, has jumped to the spinal column. Identifying characteristics, again, that coccobacillus. You're going to call this a gram-negative cocci almost every single time. If any of you do micro at St. Vincent's in Little Rock, and somebody probably will, I hope they make you gram stain this stuff every day too, because they did me. It is oxidase negative, catalase positive, non-modal. Can appear as gram-positive cocci in blood culture smears every single time. But here's the deal. What gram-positive? No, it appears as gram-negative cocci. Scratch that out. What gram-negative cocci jumps to the blood? MCAT, rarely, maybe. So if you're looking at a blood culture and you see what looks like gram-negative cocci, you need to be thinking Acinetobacter, because nothing else really makes sense in that source. Now, if you're looking at a urine and doing a gram stain, which you shouldn't, because urine is notoriously hard to gram stain, well, then maybe gram-negative cocci makes more sense. Maybe you're thinking gonorrhea and they're flushing some out. Anything like that kind of makes sense. Acinetobacter tends to be bigger than like the Neisseриas or the MCAT. It's a bigger cocci. Whereas like the Neisseриas and all that, when you look at the gram stain, they're like strep size, the little bitty cocci. These are bigger like the staph size, bigger, fatter cocci. But again, they're not truly a cocci, they're a rod. They grow in routine media. Purplish colony may resemble a lactose fermenting organism. They're talking about McConnell. It'll grow, it's not really a pink, it's more of a purple, it's a darker pink. and it looks like a lactose ferment. And again, often resistant to many antibiotics. All of these organisms are problematic. Stenotrophomonas. What you need to know about this, it's almost always nosocomial. It's the third most common non-fermenting isolate. Gram-negative bacillus, oxidase negative, catalase positive. On McConkey, the colonies will appear bluish. Hard to mistake that for lactose ferment. This one has been found in imported produce. And here's why. This is not legal in the United States. Often found in water, sewage, and plant materials. You cannot use sewage to fertilize produce in the United States. Unfortunately, in other countries, you can, and they do. The waste treatment facilities, they sell it by the tanker loads to farmers, and they spray human waste on their fields. In the winter months, where do we get most of our produce?
Other countries.
Other country.
Other countries, primarily Mexico and Central America. This is how this organism has been found as a contaminant on food products. Because they're perfectly within their right and their laws to fertilize with human waste in other countries. In America, we can't do that. You can fertilize with animal waste, which I don't see as being a whole lot better in a lot of ways, at least as far as like potatoes, waste is up here, potatoes down here, okay. Corn, waste is here, corn's up here, okay. Lettuce is right here, waste is right here. Nah, don't want to eat that lettuce. So again, wash your produce. But that's how some of this stuff, when you're talking about sewage, how does this get on food? That's how. It's not allowed in the United States, but all of our food, matter of fact, a small portion of our food comes from the United States. We import. Burkholderia. Once classified as a Pseudomonas. This is another one they changed the name. Burkholderia cepacia. It's a low-grade nosocomial pathogen, often associated with pneumonia in patients with cystic fibrosis or chronic granulomatosis disease. Been reported to cause endocarditis, UTIs, osteomyelitis, etc. Chronic granulomatosis disease. Anybody know what a granuloma is? It's almost like a fibroid tumor. It's a grainy mass. Well, imagine your lungs filling up with those. It's just knots and nodules. See that a lot in cattle, not so much in people. Grows well on routine media. BCSA media is recommended. BCSA stands for Burkholderia cepacia selective agar. It is a very weak, slow, positive oxidase. When you're doing an oxidase test and it's almost immediate, this one you're going to stand there and look at that swab for a minute, 2 minutes, and then it's going to show a positive. Which is why when you do that and you get a negative, don't just say negative and throw it down. Give it a second, hang on to it, do something else. Then look at it again before you decide it's truly a negative. Nearly all of them oxidize glucose. Most are ONPG positive, motile, non-fluorescent, green pigmented, non-wrinkled colonies. Don't care about that. Differentiation of the species is complex. Should be confirmed with either traditional biochemicals or Maldi-Toff. Remember Maldi-Toff? That is the crystallized base slide. Organism goes here, laser vaporize it, then measures how long the fragments take to travel, and based on that can determine what those fragments are made of. Or molecular methods. Gladioli, think about the flower, gladiolus. It's a plant pathogen. resembles Cepacia very much, have been found in cystic fibrosis patients, also in blood and tissue. The next one will be significant for someone in this class. Malii causes glanders, a zoonotic disease primarily affecting livestock such as horses, mules, donkeys. In humans can produce severe local or acute pulmonary infections, considered by the government to be a bioterroristic agent. There's only been one case in the U.S. in the last 50 years, and that was due to a lab accident. They self-infected. Pseudomallii causes melioidosis, an aggressive granulomatosis pulmonary disease. Can be caused by ingestion, inhalation, or inoculation of the organism with a metastatic abscess in the lungs. So metastatic like cancer. It starts, it forms this abscess, and then it goes boom and spreads throughout. Real nasty organism. Found in water, muddy soils in Southeast Asia, Australia, Mexico. Travelers to endemic areas are at risk. This organism does demonstrate that bipolar, that safety pin looking staining. It'll stain in each end and not so much in the middle. Considered to be a bioterrorism agent. Anything that can cause death and can be inhaled technically is bioterroristic agent. Should be reported to state health. The colonies are very wrinkled. If you see something that has a really, really wrinkled looking colony, get under the hood before you start working on it. Very few organisms have wrinkled looking colonies. Most of them are very smooth. So again, if you see something like that, get under the hood because you don't know what it is yet. Use MALDI-TOF for rapid ID. Most of the time they're going to go to other molecular methods. MALDI-TOF is still too new for most people. We already talked about MCAT, not going to go over it again. Very last one, Cyclobacter. Optimum growth temperature at 20 degrees. That's below, well, that's actually ideal room temperature for me. That's below room temperature for most people. Will rarely grow at 35. It's been associated with fish and processed meat and poultry. Has been isolated from urine, blood, and spinal fluid. It doesn't grow at 35 or above. I have yet to figure out how this has been found in patients, unless they're, very, very low body count. Hypothermia, maybe it'd love it. Notorious for growing on the Neisseria auger, the Thayer Martin, and it smells like roses.
Roses?
This is another one of those with those unique smells. It smells like roses. This whole slide, scratch all this from your brain. The Flavobacters, it's another one of those that's not normal flora. It's been known to contaminate hospital equipment, cause nosocomial infections. That's all you need to know about that. The first one's important, chromobacteria, because of the pigment it forms. The colonies are purple. Well, that's a problem when you're trying to do an oxidase, because you're looking for a purple color. So you really can't oxidase test this stuff, because it's already purple. You can't see a color change. So it's important in that regard, because it forms that purple pigment greater than 90% of the time. Those last two, I don't know those organisms. You're never going to see those organisms. We're not going to cover those organisms, and I certainly cannot save those organisms. That is terrible. I should make that a bonus and say spell it correctly. Elizabeth Hingia meningoseptica. Nice. Methylobacterium is kind of unique because it can actually use and live off of methanol. Methanol is pure alcohol. Methanol is used commonly as a disinfectant. It's also used as racing fluid. Could you see how this could be a potential problem? If it can live in methanol and alcohol? Because if it can live in methanol, it can live in isopropyl alcohol as well. Because it's less toxic than methanol. So it could actually live in the hand sanitizers? That could be problematic, especially if you're using a hand sanitizer and you have a cut on your hand. That's the only thing that's really, that's really the only thing that's significant about that. Roseamonas, don't confuse it with the other one that smells like roses. This one doesn't smell like roses. It's called that because it's pink. Looks like pink rose. The colonies do. And again, there are others too numerous to cover. I have seen Ralph Stone. There are a bunch of them. Vanilla. Only important because they can produce H2S, so they can resemble some of the enterics. You do the oxidase test, it'll differentiate them from that. That's all you need to know about Shellwanella. It's an H2S producer. So you just gotta be able to rule that out. So points to remember about these organisms. Non-fermenters will not acidify the butt of TSI. Most non-fermenters are usually oxidase positive, and that is the key test to differentiate them from the enterics. Non-fermenters are typically environmental. They rarely cause disease in healthy humans. They're opportunists for the most part. They are found in a variety of hospital environments and can colonize inanimate objects and solutions, serving as a possible source of infection, especially in someone who's compromised. As they figure out more and more places this stuff can live, they're fixing this, which is why they've changed the way they sanitize respiratory equipment. They've changed the way they produce and sterilize fluids for infusion. So as this stuff crops up, they're fixing it. Of all the gram-negative isolates that you see in a lab, about 30% of them will be non-fermenters. The three most common are Pseudomonas aeruginosa, Acinetobacter, Stenotrophomonas multifilium. And Pseudomonas aeruginosa leads that pack by a considerable margin. Specimens from patients with cystic fibrosis often demonstrate a wide variety of non-fermented bacilli. It may require that more definitive ID methods be used. Cystic fibrosis is a lung disease. Their lungs are rigid and they can't expel a lot of this stuff, so anything that gets in there stays. You see a wide variety of organisms from cystic fibrosis patients, and a lot of them will be non-fermented. MALDI-TOF or DNA sequencing will be needed to confirm the ID of all of the non-fermenters. Anyone who IDs in-house a non-fermenter is going to have to use the phrase presumptive Pseudomonas aeruginosa, because it is so inert on a lot of these biochemicals, giving a definitive is very difficult. But for most physicians, if you can give them a presumptive and a good susceptibility chart, they're not very concerned about it. Because again, if, in my opinion, and some people disagree, if I know how to kill it, what do I care what it is? You tell me the antibiotic to kill it. I don't care the name we put on it. We determine that this is significant, and you tell me this antibiotic will kill it. I don't care what it is. Give them this antibiotic. End of slideshow. A lot of organisms in this group, not very many of them are significant. bits and pieces here and there, and then like two you need to know quite a bit about. Primarily Pseudomonas aeruginosa. You need to know a lot about that one. 'Cause I promise you, you're gonna see that one a lot. And again, Pseudomonas that's the bug that scares me. Because I see in 5 to 10 years, it will be resistant to all antibiotics. People are worried about this, MRSA, this resistant staph. That doesn't bother me that much. Pseudomonas is getting scary.
Right.
I mean, it's gotten to the point now where, like I said, if you test 15 antibiotics, it'd be resistant to 14.
It's crazy.
So it's getting scary, it's getting really, really fast considering 20 years ago, it wasn't resistant to any of them. Alright, so we are done. We're doing lab.
Yay. I like that.
We're going to do a cross match, a screen and a play. Let's go on.
A what?
Cross match.
Oh, okay.
One vote for 11.
What are you saying here? I'm sorry.
One vote for 11.
I'll vote for that.
Yeah, that's
One
fine.
suggestion of 11.
Anybody have a problem with that?
11?
Yeah,
Hello?
11 it is.
you're okay. Yeah, 11's
Huh?
have it.
You said 11.
Shut up.
You have
So
some trio
confused.
beans.
11
I'm
it
not
is? I
stealing.
couldn't get any response.
I am in trio.
Baby, you can get them.
You need to start later?
No, that's why I was asking.
Oh.
It's nice. It works really well.
I have to go steal the trio beans.
Oh, you can have that one. I have another one. Here you go.
No, you gotta be careful with
You don't
Jason.
need that, you need to write a live notes.
Jason's trying to steal one of my kids one of these days.
I am.
No, you're not.
Yeah, I am.
How about I buy you a pack of Christmas?